Welcome to our video on neuroblastoma and Wilms tumor. Let's get started. Here's our overview slide. Let's begin with neuroblastoma. With regards to neuroblastoma, we'll be discussing the general features, pathophysiology, clinical presentation, diagnosis, and management. Let's begin with some general features. Neuroblastoma is a neuroendocrine tumor most commonly in patients less than 4 years of age. It's frequently found in the adrenal medulla. However, it can occur anywhere along the sympathetic chain. Now let's discuss the pathophysiology. It's classified as an amine precursor uptake decarboxylase tumor, or APUD tumor. APUD is an enzyme that produces bioactive amines such as catecholamines via decarboxylation. Neuroblastoma is derived from the neural crest cells, and it's characterized by overexpression of the NMYC oncogene. NMYC codes for a transcription factor. Neuroblastoma produces catecholamines like norepinephrine, epinephrine, and dopamine. It most commonly presents as a firm, irregular flank mass crossing the midline. This is in contrast to Wilms tumor, which presents as a smooth, regular mass that does not cross the midline. Patients with neuroblastoma are usually normotensive despite catecholamine production because catecholamines are rapidly degraded. Children with neuroblastoma may have a paraneoplastic syndrome called opsoclonus myoclonus syndrome. It's also known as dancing eyes, dancing feet, due to non-rhythmic irregular movements of the eyes and feet. The diagnosis occurs first by measuring vanillomandelic acid, or VMA, as well as homovanillic acid, or HVA, which can both be found in the urine. VMA is the end product of norepinephrine and epinephrine metabolism, while HVA is an end product of dopamine metabolism. A CT scan of the abdomen and pelvis is done to localize and stage the tumor. A biopsy of the mass usually shows Homer-right rosettes on microscopy. These rosettes consist of neuroblasts surrounding the central lumen. Homer-right rosettes can also be seen in medulloblastoma. The tissue specimen is usually positive for bombesin and neuron-specific analase. This is an image showing Homer-right rosettes. And notice that there are several neuroblasts surrounding a central lumen. Okay, moving on to management. Choosing the right treatment regimen for neuroblastoma is complex and beyond the scope of step 2. However, it's worth noting that chemotherapy, radiotherapy, or surgery can be used in the management depending on the stage of the tumor and the risks for complication. All right, let's try a question. A 3-year-old girl is brought to the physician by her parents reporting a right-sided flank mass. The mother first noticed the mass while bathing her daughter 4 days ago. Parents have also noticed that she moves her eyes back and forth and she has a constant urge to move her feet. The physical exam shows a right-sided flank mass that crosses the midline. The abdominal ultrasound shows a right adrenal mass. What is most likely to be found on the biopsy of this patient's flank mass? All right, this patient has a right adrenal mass that crosses the midline. Additionally, she moves her eyes back and forth, and she has a constant urge to move her feet. This description is consistent with opsoclonus myoclonus syndrome, also known as dancing eyes, dancing feet. Given all of these findings, the most likely diagnosis in this patient is neuroblastoma. A biopsy of neuroblastoma usually shows Homer-right rosettes with neuroblasts surrounding a central eosinophilic lumen. Okay, now let's move on to discuss Wilms tumor. With regards to Wilms tumor, we'll be discussing general features, genetic abnormalities, clinical presentation, WAGR complex, Denise-Dash syndrome, Beckwith-Wiedemann syndrome, and the diagnosis and management. Let's begin with general features. Wilms tumor is most commonly diagnosed in children from 2 to 4 years of age. It's a malignancy of immature renal parenchyma. This is why it's also known as nephroblastoma. Genetic abnormalities characteristic of this tumor include loss of function mutations in WT1 or WT2 genes on chromosome 11. These genes code for the transcription factors important for urogenital development. Wilms tumor can be associated with several genetic syndromes that we'll discuss in the next few slides. Wilms tumor presents as a smooth, regular flank mass that does not cross the midline. This is in contrast to neuroblastoma, which, as we already discussed, crosses the midline. Wilms tumor can also be accompanied by hematuria and hypertension. One genetic syndrome that includes Wilms tumor is WAGR complex. This complex is caused by a WT1 gene deletion on chromosome 11. It's an acronym and stands for Wilms tumor, aniridia, which refers to an absent iris, genitourinary malformations, and range of developmental delay. Another syndrome associated with Wilms tumor is Dennis-Drash syndrome, caused by a WT1 mutation on chromosome 11 rather than a deletion on chromosome 11. Apart from Wilms tumor, this syndrome is characterized by diffuse mesangial sclerosis with early onset nephrotic syndrome and gonadal dysgenesis. Patients with this syndrome usually have 46XY disorder of sex development. In other words, they're genotypically male, but their external genitalia are undervirilized. The last syndrome that we're going to discuss in relation to Wilms tumor is Beckwith-Wiedemann syndrome, and this is caused by a WT2 mutation on chromosome 11. Beckwith-Wiedemann syndrome is characterized by Wilms tumor, organomegaly, macroglossia, hemihyperplasia of the body, and omphalocele. Here are some images that highlight some of the clinical features of Beckwith-Wiedemann syndrome. The image at the left upper corner exhibits macroglossia. The image at the left corner shows fetal macrosomia, while the central photo exhibits hemihyperplasia of the right upper extremity. Finally, the right image shows a neonate with omphalocele. The diagnosis of Wilms tumor requires abdominal imaging. Abdominal ultrasound is usually preferred over CT scan. Additionally, a chest CT scan should be performed to look for pulmonary metastasis. Finally, a biopsy confirms the diagnosis. Treatment includes a combination of surgical excision, chemotherapy, or radiotherapy. All right, let's finish up with a final question. A 3-year-old boy is brought to the physician by his parents reporting a left-sided flank mass. The mass was first noticed several days ago by his mother when she was bathing him. The physical exam shows a left mass that does not cross the midline. The patient has periorbital and peripheral edema. The external genitalia are severely undervirilized. Urinalysis is significant for 4+ proteinuria. What is the most likely morphological change in renal tissue that best explains this patient's urinalysis findings? All right, this patient presents with a left-sided flank mass that does not cross the midline. This presentation likely suggests Wilms tumor. His external genitalia are severely undervirilized, indicating that he has a 46XY disorder of sex development. Finally, his urinalysis is significant for 4+ proteinuria, and the patient has periorbital and peripheral edema. These later clues indicate the presence of nephrotic syndrome. The triad of Wilms tumor, gonadal dysgenesis, and an early onset nephrotic syndrome is characteristic of Dennis-Drash syndrome. The morphological change in renal tissue that best explains this patient's nephrotic syndrome is diffuse mesangial sclerosis. And that concludes our video on neuroblastoma and Wilms tumor.